Chapter 27 is the cerebral dysfunction part 4, and we're talking about submersion injury, which we used to call near drowning. So how we're going to manage them really is on the degree of cerebral insult. How long did that brain go being hypoxic? The first thing is to get oxygen to the brain, right? Restore O2 delivery. In submersion injuries, kids quit breathing and then have a cardiac arrest. So often when you pull them out, they're going to need some rescue breaths. They may not need full CPR. Their heart may be working. They just need to get oxygen back in. Any kid who's had a submersion injury should be hospitalized and observed for a minimum of 6 to 8 hours because respiratory distress can get worse. Cerebral edema and increased intracranial pressure can get worse. So we want to watch them to make sure how they're doing. Aspiration pneumonia, we said, respiratory was a problem, right? This often doesn't really show up for 48 to 72 hours. So we need families, even if they do get sent home, to be watching for that. And then we just need to support and work with these parents. They are going to be struggling to cope, partly because of guilt that they feel like they shouldn't have let it happen, and partly just the stress of having, a child who has a potentially life-threatening this problem going on. So let's help parents to cope and get onto a prevention side instead of just blaming themselves. So if they have a swimming pool, let's get it fenced. If they have toddlers, we want to make sure there's not buckets of water around or that the lids to the toilets are kept down, those sorts of things. Moving on to bacterial meningitis. This is an acute inflammation of the central nervous system. We see a lot less of it with immunizations these days. The most common infectious organism used to be Haemophilus influenza, which is our Hib vaccine. And we're also doing pneumococcal vaccines. So those are two of the common germs that are now should be prevented with immunization. So common bacterial agents, Streptococcus pneumoniae, Neisseria meningitis. You'll hear that called meningococcal, or sometimes people will say Neisseria disease. Those all are Neisseria. That's a really bad germ for meningitis. A couple hours delay in treatment makes a difference in a good versus a bad outcome. Our beta hemolytic streps, Listeria, and then E. coli, although E. coli doesn't happen often after infancy. And part of the problem with bacterial meningitis with infants is they really don't have a blood-brain barrier, not till they're about 3 months old. So an infection anywhere can get picked up into the bloodstream because babies don't isolate infection well. So whether it starts as a UTI of E. coli or something else, it gets picked up into the bloodstream and then it crosses into the meninges, and now we have meningitis, which is a life-threatening infection. And here's a picture of, I said meningococcal is really bad. This is often happens with it. Okay, so the pathophysiology of meningitis. How the germs get in there doesn't really matter. Often they start somewhere else and then get picked up into the bloodstream and cross. Sometimes they start as an ear infection or a sinus infection and move. But whatever happens, the meninges surrounding the brain become inflamed. They produce exudate, right? White blood cells come, cell breakdown, you end up with basically pus. So we have a huge amount of white blood cells and tissue damage. Because of this, the brain becomes hyperemic and edematous. So we send blood there to get white blood cells to it, but that extra blood volume makes some increased intracranial pressure and makes it edematous. And then we get impaired flow of the CSF because we've now blocked it with swelling and with pus. So what are you going to see? Symptoms usually are quite sudden: fever, headache, vomiting, altered senses, seizures, mucorigidity. This is a very sore neck. If you move the head forward so the chin is touching the chest, that's really painful. Our book talks about Koenig and Brudzinski signs, which is if you try and lift the leg, they're going to curve their back, or if you have the leg up and try and straighten, it's very painful. And then photophobia. Light makes the headache and the nausea and everything worse. So for labs, we're really looking at that lumbar puncture. We're trying to look and see what's in there. We're going to put it on a petri dish and do the culture and sensitivity to see what grows. But we're looking at, did they see bacteria when they looked at it under the microscope? Did they see white blood cells? What's the protein and the glucose of it? In bacterial meningitis, we tend to see high protein, high white blood cells, and low glucose. If possible, you want to compare that glucose to the serum glucose, though, because if the child's been sick, their glucose may be low, so even though it's low in the CSF, it's low in the blood, so it's okay. Or it may be high in the blood because they're having a stress response to the illness. So it's best if you can compare them. And what happens with the infection, you get increased permeability between the blood-brain barrier, and that's because we're trying to get white blood cells in there to try and get rid of or minimize the germs in there. And on that blood culture, you're going to see an organism growing. Back in the day, I was taught to remember this, that the germs look like protein when they look at it under the stethoscope or the microscope, and the germs eat up all the glucose. So that's why you see high protein and high and low glucose, and we've sent white blood cells to kill those germs. Okay, that I have since learned that is wrong pathophysiologically, but if it helps you to remember, that's what you're going to see in bacterial meningitis: high protein, low glucose in the CSF. So how do we treat this? Well, this can be transmitted airborne, so they're going to be on respiratory isolation until they've been on the correct antibiotic for 24 hours. The most important thing is getting those antibiotics started. Remember, we've always got to get all of our cultures done before starting the antibiotics, because if you take CSF fluid or blood or whatever that's got antibiotic in it and germs in it, well, the germs aren't going to grow on the petri dish because there's antibiotics with them. So get the labs done, get those cultures sent, and then immediately start antibiotics. Hydration and things to reduce the intracranial pressure. We said they have headache, photophobia, so decreasing the lights, decreasing the sounds, any other nursing measures that are going to keep them comfortable, reduce that ICP. They're at higher risk for seizures, and they're probably running a temperature, so watch for those, and then good neuro assessments. How do we prevent it? We have vaccines. The meningococcal vaccine is now being given between 11 and 12 years old, and then again at 16. It's not automatically given to younger children, but if they're at risk, it will be. The Hib vaccine is given at 2, 4, 6, and 12 months. So that one used to be our most common germ, and now we don't see it very often at all. Pneumococcal immunization, again, starts at 2 months, and we're seeing less meningitis these days. Non-bacterial meningitis means it's probably viral. Some of the things that can cause it, measles, mumps, herpes, can be part of cancer, leukemia. Our enteroviruses are a large contributor to our non-bacterial meningitis. Remember, those are a fecal oral transmission, so they came out of somebody in the stool and got into somebody else. So good hand washing, cleaning diaper changing areas, those are going to minimize this. Symptoms are less severe, although somebody who's had a viral meningitis will tell you they were miserable. It's a virus. Most of these will just run their course and they'll be okay long term. We're just treating for symptoms in the meantime. When we do that CSF, if we find white cells, they're going to be lymphocytes, mostly monos. And also in the blood, that's probably what you'll see. Encephalitis. Encephalitis just means inflammation of the brain. And at least half the time, we don't know what causes it. Some things that can cause it, it can be vector-borne, and in our area, that's going to be things that are carried by mosquitoes or ticks. It can come as a post-infectious involvement of the CSF after certain viral diseases like herpes. Onset, it can be gradual or sudden. It really can be non-specific. Malaise, fever, headache, stiffness, tremors. This progresses till they really aren't able to follow directions or just really have severe changes to their level of consciousness, can lead to coma and death. Most of the time our treatment is just supportive. If we think it's something viral, they'll give a cyclovir, particularly if they think it's a herpes thing. If they think it's maybe an autoimmune thing, we may give immunoglobulin. But this is a kind of difficult thing because we're not sure what causes it, so we're not sure how to treat it. Most of the time they do okay afterwards, but not always. Rabies. This is a viral infection that needs to be treated because once you have symptoms, it is fatal. It's transmitted by the saliva of an infected animal, and in our area, most often it's going to be raccoons, skunks, foxes, or bats. And kids should not approach wild animals, whether they're friendly or not. And if the animal is acting weird, that's even more reason not to approach them, because one of the symptoms is maniacal behavior, so bizarre behavior, and frothing at the mouth because they have an incredible aversion to swallowing. The incubation time for this is anywhere from 1 to 3 months, usually, but it can be as little as 5 days and as much as 6 months. And here's a raccoon. Stay away. So what happens is you get a bite, the whole brain becomes inflamed, and as I said, once you have symptoms, it usually results in death. So our best way is prevention. Stay away from those animals, or if you do get bit, we're going to give you the rabies shots. We give an inactivated rabies vaccine. The first day we give it is day 0, and then again on day 3, 7, and 14. That is to get you to make active resistance against it. We're also going to give you immunoglobulin to give you some passive resistance against it. We give both of those. Now they're starting to do that immunoglobulin at the site. So wherever the child was bit is where they're going to inject that immunoglobulin rather than just as a shot. So the wound of the bite, we want to clean it thoroughly. Consider antibiotics because this one's viral, but you can get it infected. You want to keep it open, so if there's something can drain out, we let it drain out. If we know the animal, they will isolate the animal, and if the animal has no symptoms in 10 days, then they'll stop. They won't give you that last shot on day 14. Or if the animal can be killed and they can do testing of the animal's brain tissue, then they can know for sure if the animal had rabies or did not, and so they can treat or not treat.